introduction before the plenary talk. And now we have a presentation by Simone Stella, who is a PhD student in the iHEART group at MOX Department of Mathematics in Politecnico di Milano. And this presentation will be about computational estimation of latest activation time in view of the cardiac resynchronization therapy.
Okay, thank you, Pasquale, for the introduction. Can you see the presentation?
Everything is fine, please go ahead.
Okay, perfect. Okay, perfect. So, this work is in collaboration with Professor Cristian Vergara, Professor Alfio Quarteroni, and Pasquale Africa from MOX, and Professor Fabio Nobile from EPFL, and Dr. Maurizio Del Greco and his collaborators from Ospedale di Rovereto, Santa Maria del Carmine. Okay, just a brief introduction. As said before by Professor Niederer in his plenary lecture, the ventricular dysynchrony is characterized by an uncoordinated contraction due to asynchrony between different regions of the ventricles, between two ventricles, interventricular dysynchrony, or intraventricular dysynchrony, when we have different regions of the same ventricle, which are asynchrony, which may lead to heart failure. In the last years, last 20, 30 years, heart diseases were discovered and treated with defibrillator, pacemaker, and etc. But a lot of attention has been paid to ventricular dysynchrony. And to treat this pathology, cardiac resynchronization therapy aims at restoring the physiological synchronism of the heart contraction, placing two pacings to restore the ejection fraction. The main pathology, the main cardiac pathology, conduction abnormality treated with CRT is the left bundle branch block. It results when the normal activity, electrical activity of the ventricle in the left part of the His-Purkinje system is interrupted. What about CRT, CRT methodology? The critical choices of the cardiologists performing CRT are two, pacing sites and delayed. About the pacing sites, they can choose between left pacing. So nowadays there are no shared criteria. The main possible choice used in literature and especially in Rovereto Hospital is the latest activation time point. And about the right pacing, there are no electrical criteria, usually is placed closest to the apex. About the delay between the two stimuli, nowadays in clinical practice, they are heuristically determined. But CRT has a non-responder rate up to 30%. So we have no shared criteria in CRT methodology. And the critical choice of the cardiologists leads us to the possibility to explore different scenarios. The clinical goals we want to achieve is to reduce the non-responder rate, reduce the clinical invasive procedure time, and also the radiation's time exposition. First of all, we move to the first step towards the validation of the monodomain model in a context of a normal excitation with sinus rhythm. So no tachycardia, no fibrillation, no stimulated cases. Briefly, this is the formulation of the monodomain model, and we coupled it with the ionic current I ion chosen according to the Bueno-Rovio ionic model. I want to underline that for us, for our purposes, we imposed the external applied stimulus I up as the activation time measures at the septum acquired by clinicians. We will see later this. Okay, clinical data. We have at disposal 4 patients who underwent CNMRI steady-state free precession ECG retroacquisition, and also a mapping of the septal surface in the right ventricle and of the coronary veins at the left ventricle epicardium with the Inside Precision software acquired at Ospedale Santa Maria del Carmine in Rovereto. So how to merge these two types of data? To include in our simulation these two types of data, electrical and geometrical, we perform the procedure depicted here in the slide. So we focus on 3 points, electrical points, and the same 3 points in the geometry. So we rotate and translate the electrical point cloud to the geometry, reconstructed geometry, And then through an Euclidean nearest neighbor search, we project all points on onto the surface, onto the epicardial surface of the ventricle. What about the electrical data subdivision? We subdivided all electrical data at disposal into 3 main groups. The first one is the septal data. So the data acquired at the septum, and we impose these, we provide this as input to the current in the monodomain model. The second group is the epicardial veins data, group 1, which corresponds to the first half of the epicardial veins measures that we have at disposal, in particular the earliest activation time, and we used this for the calibration. The second group consists of the remaining half of epicardial veins measures, in particular, so the highest activation times, and we use this for the cross-validation of the model. About the estimation of conductivities. So the goal was to maximize the agreement between numerical simulations and clinical measurements. So to do so, we performed a minimization of the discrete functional, depicted here, with a basic direct search approach, starting by an initial guess, sigma, of the conductivity, and ongoing corrections obtaining by solving the monodomain problem and evaluating at each time step, at each simulation of the monodomain, the functional results. About the results, here are depicted the 4 results obtained with LifeX, the code developed in-house here at MOX. The 4 patients analyzed, we computed the relative error and the standard deviation over the total number of epicardial veins measurements belonging to group 2. As I said, the group we used for the cross-validation. So we have, for all cases, the error less than 6.2% and with a very low standard deviation. But we are focused, we want to focus on clinical implications of this. So now we have the capability to estimate with good accuracy the point with latest activation time, which is commonly used in CRT to locate the left electrode. And also to reduce the mapping procedure, because we can use less points, less measurements, clinical measurements, to produce a good agreement between numerical simulations and clinical measurements, so we can reduce the clinical invasive procedure time and radiation exposition time also. So we added 7 patients affected by LVBB, left bundle branch block. Now for these 7 patients, we have 1 more data with respect to before, which is the bullseye plot. The bullseye plot, when in absence of a specific and accurate clinical machines, which is able to reconstruct the fibrosis or the presence of scars in the ventricle of the patients, radiologists usually use this bullseye plot. So they subdivide the left ventricle into 17 volumes and report for each block if a fibrosis is present more than 75%. So we developed a tool to manage this bullseye plot with fibrosis. So we can assign different conductivities in each segment of the block, in each segment of the bullseye plot. For example, 2 areas of low conduction, 1 area of medium conduction. So the software is capable to subdivide the geometry into 17 subvolumes, assign different conductivities, and merge together to a whole left ventricle geometry to be used in the simulations, numerical simulations. But just to recap, in clinical practice, performing CRT, the location of the left electrode is the location of the latest activation time point. Usually, this is the point used for the left electrode. So our goal is to show the ability of our validated computational method to well predict the value of the latest activation time point, the value and the location. We are able to compute the lat point on whole coronary veins, but only if the complete vein geometry is available. Using MRI data that we have at disposal is not possible to reconstruct the whole coronary veins. So we try to reconstruct the coronary veins from the electrical data we have at disposal. So we further analyzed electrical data to reconstruct the geometry of the coronary veins, following a 3D reconstruction procedure using splines in parallel. The choice of the control points in the splines, the number of the control points in splines is crucial, because if we choose a too low number, the vein is too smooth, too straight, or if we choose too high number, the vein is too irregular, and it can happen that we have 90 degrees angles in the vein. So we can perform from electrical data, we can have the reconstruction, a good reconstruction of the veins used for the veins for the measurement, the veins that have the electrical measurement. And then we are now able to, as said before, for the first work, to use the data of activation time and disposal, the epicardial veins, to estimate the conductivities in the monodomain equation. So now we have two different kinds of patients. Patients without fibrosis, so we assumed conductivity to be constant in the whole myocardium, and patients with fibrosis. So we differentiated the conductivities in the bullseye segments characterized by the presence of the fibrosis. For the selection of the conductivities, we minimize the discrepancy between the measurements and the computational results. So the activation times computed by the software and the activation times clinically measured. We are now able, in this way, to compare three important latest activation time locations, which are the measured LUT, the point where the clinical measures was made, the computational LUT, so the location of the computational latest activation time point on the reconstructed vein, and the computational global LUT, the computational location of the latest activation time point in all the epicardium of the ventricle. Here are some numerical results. For each patient, on the left, we have the computed activation maps and measurements of activation time, the bullets. And in the right, we have the location of the latest activation time points. The star is the measured LUT, the triangle is the computational LUT, and the diamond is the computational global LUT. So just in this slide, in the figure, we can qualitative compare that, we can qualitative say that we have a good agreement between the latest activation time point measured and computed. And also we can we can localize the diamond, the computational global LUT point. But numerically, quantitatively, we measure the mean relative error as said before, as done before, but also three important distances. D1 is the distance between the measured latest activation time point, the star, and the computational latest activation time point, the triangle. D2 is the distance between the measured latest activation time point, the star, and the computational global latest activation time point. And finally, delta AT, which is the difference between the measured activation time, latest activation time point, and the computational global LUT. And we found that the distance D1 between the measured and the computational latest activation time point is in any case less than 0.5 centimeters, so it's very close. We found obviously a discrepancy between the measured latest activation time point and the computational global latest activation time point on the epicardium. This point is not reachable by the veins, but we want to highlight the presence of this point because CRT can be performed also in a more invasive way. So there is a possibility to explore all the epicardium of the left ventricle. Just to summarize, okay, we developed a pipeline able to take as input the MRI data, electrical data, in this case, and site data, but it's not mandatory, and bullseye plot. We can manage all this data. We can reconstruct the geometry. we are able to subdivide following the bullseye division and assign different conductivity values to each region. We are able to align the data, the electrical and geometrical data, and subdivide the data into 3 groups to perform calibration and validation. We are able to perform numerical simulation and parameter estimation, and to reconstruct the epicardial veins followed by clinicians in CRT practice. And as output, we are able to localize these 3 points, computational LUT, computational Roman LUT, and measured LUT, to find discrepancies between these 3 points and to localize the best point for the left electrode in CRT. Work in progress, we are investigating on the influence of the registration procedure. So when we merge 2 data together, electrical and geometrical data, and we are moving to electromechanical simulations to evaluate the influence of the compliance in CRT outcome, for example, ejection fraction, dP over dt. And we want to optimize in sense of positive outcome, clinical outcome, so reducing the non-responder rate on the choice of the left and right electrodes and the delay between them. Okay, thank you.
Okay, thank you, Simone, for your presentation. We have time for a couple of questions.
I raised my hand. This time is real. If I can ask.
Please go ahead, Professor Trajanova.
Hi, Simone. I was wondering, when you incorporate the information about the fibrosis distribution, do you also incorporate information about the signal intensity in the scan, or your conductivities are based on just the amount of fibrosis in the LV segment?
Okay, if I understood correct, okay, when I incorporate, you're saying when I incorporate the value of conductivity in the model, okay, which value
No, what I understood is that in each segment, you report from the clinical scan the amount of fibrosis. Is that correct?
It is not perfectly correct, because I don't report this. Clinicians report to us these values. We have from clinicians just the bullseye for the patients, and we have highlighted the areas here, fibrosis, here, no fibrosis.
So you do not have any information, even if it has fibrosis, it can have different intensities of which would be more focal scar, more diffuse fibrosis. You do not have that information.
No, for the moment, no, we don't have this information, but it can be implemented easily in the model, because we can differentiate the conduction in each segment. And also it is possible to extend this model to subdivide each subregion to endocardial, epicardial subregion, and so differentiate again the conductivity. But for the moment, we choose as a first step to give the same conductivity to each segment.
Yeah. Thank you.
Thank you.
Okay, so I see another question in the chat by Professor Niederer. He asks.
I can ask that.
Okay, so please.
Sorry. Simone, are you able to account for the residual error in the registration between the MRI and the electroanatomical map, which will be some distance?
Mm-hmm.
Because the MRI is going to be like a month, 3 months before, depending on your center. Do you account for that residual and that projection when you're doing the activation times? And are you able to calibrate that residual based on the local conduction velocity that you're seeing in that region?
Okay, we didn't do this, but yeah, we can take into account this, because this was the first problem we faced.
It's a nightmare. Nothing ever adds up. The patient's hearts are never the same.
And so we tried to find a way to couple these two data, but we are now investigating on a sort of sensitivity analysis on the registration, because we know that this counts in some sense, but no, I cannot answer. I cannot answer properly because we didn't do any calculation about this for now. But
you can expand the standard deviation you have on your active or your uncertainty interval on your activation time at each local point. And then when you do your fit, you can account for that. So that might be something you could consider looking at. It's just a way to deal with that.
Okay, thank you very much.
Okay, so very quickly, one last question from Alessandro Barone. Could you please comment a little more on the optimization algorithm for conductivity estimation?
Okay, yeah. Okay. For this first step towards the validation, we choose a basic direct search approach. We know that there are a lot of algorithms to improve, to have a minimization approach. But for now, we choose this approach, starting, as I said, from a reference choice of conductivity, choice taken in literature, and then adjusting ongoing corrections, solving the monodomain, and trying to reduce the discrete functional. So I know that there are minimization approaches, algorithms that works for this problem, but as a first step, we choose the basic direct search. I don't know if, because I cannot read the chat.
Okay. So